Hi everyone, my name is Brandon Allen. I'm an emergency physician and a primary investigator for the STOP-CP research study. I'm humbled and honored to be able to present our abstract as an SAM plenary, which is titled One and Done, Performance of a Single Low High Sensitivity Troponin in a Multi-Site United States Cohort. Some of our pertinent disclosures for this, as you can see, some of very renowned researchers in emergency medicine are a part of this study group, and they've done research both with industry as well as federal funding. A little bit about the background of chest pain. It's no secret to you guys that 15.5 million people in the United States suffer from cardiovascular heart disease. And the American Heart Association reports that a heart attack occurs every 41 seconds in the United States. Heart disease is the leading cause of death in the United States. And chest pain is among the top reasons for emergency department visits. A little bit more about the background of our study and the primary objective. We used the high sensitivity troponin T assay. This was FDA approved in January of 2017 as the first high sensitivity assay. Now, it's titled Generation 5 assay by the FDA because it did not meet all of the criteria by the IFCC for high sensitivity. However, for this study, we used cut points below the limit of quantification, which is in line with European data. So there's a couple of key definitions that are important to know, and the limit of quantification is the lowest number that's able to be recorded for the assay. The limit of detection is the lowest number that's able to be seen by the analyzer. And for this study, we use the limit of quantification, or the LOQ. Furthermore, starting as early as 2010, Europe data suggests that a single high sensitivity troponin result below the limit of detection excludes major adverse cardiac events, or MACE, in patients with symptoms concerning for acute coronary syndrome. However, the United States and the FDA limits high sensitivity troponin numbers to the limit of quantification. And there's a paucity of US data and lack of multi-center data in the United States to support any practice change based off of that. So this goes to our study objective. The objective of this study is to test the diagnostic performance of an initial high sensitivity cardiac troponin T measure below the LOQ in a multi-site US cohort. Can we answer the question of high sensitivity troponin, one test and safe for discharge or done? A little bit about the overall STOP-CP study. You guys have probably been wondering what STOP-CP stands for. Well, my co-primary investigator, Dr. Simon Mahler, coined the term based on the acronym, High Sensitivity Cardiac Troponin T to Optimize Chest Pain, STOP-CP. So for this study, we had a prospective observational cohort group, and we looked at 8 sites across the United States, and the patients were assessed based on the chest pain or symptoms suggestive of acute coronary syndrome. It lasted from late January 2017 to early September 2018. Here's our map of the respective sites across the country. As you can see, the Midwest was not present on our enrollment sites because the sites that we approached were already on the high sensitivity troponin T, which excluded them from being an enrolling site. Our study inclusion and exclusion are quite basic for cardiac biomarkers research, nothing out of the ordinary. Exclusion criteria of STEMI, of course, shock, and lack of capacity to consent and lack of follow-up. I think it's important to describe how we ran the STOP-CP study so then we can get into the actual abstract data of the one and done strategy and the assessment of its performance. So for STOP-CP, we had an ED arrival, and if they met inclusion criteria after screening, they were enrolled. Well, one of the challenges is that the respective sites were blinded to the high sensitivity troponin result. So we went with the contemporary assay of those respective sites, and we tried to get the enrollment or high sensitivity assay for the study as close to the contemporary assay as possible. And we gave ourselves a window of 1 hour. We did serial troponins for the study at 0, 1, 2, and 3 hours, But in respect to this plenary presentation, we're going to focus on the first or time zero. After the initial blood draws in the index visit, which was reviewed, the providers at the bedside were asked to fill out a treating provider survey, which gave us information about clinical decision rule data, as well as the onset, quality, and character of someone's chest pain if it was indeed present. Following that, they had a follow-up review with a phone call and medical record review. It's also really important to point out how we got to our outcomes, and this is through adjudication. We used both cardiologists and emergency physicians to review the cases of these patients with the contemporary assay as well as the high-sensitivity troponin with the primary outcome of MACE, or major adverse cardiac event, at 30 days. This was also with the secondary outcome of cardiac-related death, or MI. Cardiac-related death was based off of the Accord trial definition, and cardiac revascularization was based off of a CABG or PCI. It's also important to point out that we use the fourth universal definition of MI, which helped the adjudicators differentiate from a type 1 and type 2 myocardial infarction, which was a part of their study definitions and guidelines. The statistical analysis for this plenary abstract is that we use basic statistics of negative predictive value and sensitivity with exact 95% confidence intervals. For the overall STOP-CP study, we enrolled nearly 1,600 patients. And we excluded about 120, and those were mostly secondary to lack of a second troponin at the study site, or that we couldn't get them in a timely manner. The patients eligible for analysis for STOP-CP was 1,462, and we only lost 64 to follow-up, or a little under 5%. The primary outcome of 30-day MACE was included in 14.4% of this group, and in comparison to other U.S. studies, our event rate is actually higher and in line with what European studies have cited in the past. Instead of a big, busy table, we decided to come up with bullet points for what are the study characteristics of the larger STOP-CP study in those over 1,400 patients. Well, 46.3% of them were women, 37.1% were African American, and the mean age was almost 58 years old with a standard deviation of nearly 13 years. In regards to this abstract, we wanted to look at the distribution for the patients under the limit of quantification. And as you can see from these numbers in the pie chart, a third of the group from the larger STOP-CP study were included in where their first troponin was under the limit of quantification. This is not insignificant. And for that group, we found that they're likely to be female, younger, and more likely to be Hispanic or Latino, which was statistically significant. Okay, now let's talk about the performance of the assay at or below the LOQ. So on this bar graph here that you see, black is the 30-day MACE, and red is the death or MI at 30 days. The negative predictive value for 30-day MACE was 98.3%, under 99%. And for death and MI, the negative predictive value was right at 99%, but the confidence interval, the tail, looks to be lower than that. And for the sensitivity, they're both under 98% or 99%, respectively. Shown in a different manner, the dotted line on this graph is the LOQ for the United States for high-sensitivity troponin T at 6. What this actually shows is that under 6, we likely have a very safe assay with a true 99% negative predictive value for both MACE and death or MI. However, as stated earlier, the FDA will not allow us to report under 6 at this time. But for STOP-CP, we recorded down to 3. So that's how we have this data here where it looks like the actual sweet spot of safety is at 4 or less. All studies have some limitations. Some people may consider these strengths, maybe weaknesses. One is that sites were mostly urban academic centers. Our cohort had a higher MACE or event rate than many prior U.S. studies. Our loss to follow-up was only 4%, which in most studies it's 10% or more. We see this as a strength. However, for those 64 patients that were lost to follow-up, we don't know their event rate, so that has to be in consideration as a limitation. And also, we only utilized the Roche high-sensitivity troponin T assay. This was not a comparative study with other assays, including high-sensitivity troponin I. In conclusion, use of a single high-sensitivity cardiac troponin T measure below the LOQ may not be sufficient to rule out 30-day MACE and had insufficient sensitivity for 30-day cardiac death or MI. I think what this shows is that we probably need to mirror what Europe has done and report down to the limit of detection if possible, where I think we have a safer safety profile, which would also lend itself to what the European Society of Cardiology guidelines suggest. This study has many people who need to be acknowledged for their efforts. First and foremost is the University of Florida as the coordinating center and primary site. Couldn't have been done without the great research coordinators and team we have here. My co-primary investigator at Wake Forest, Simon Mahler, as well as our great site PIs, Dr. Rob Christensen, who did the central lab and all the analysis, Dr. Troy Madsen at University of Utah, Dr. Bryn Mumma at UC Davis, Dr. Richard Nowak at Henry Ford Health System in Detroit, and Dr. Gentry Wilkerson at University of Maryland. Also, this study wouldn't be possible with the data without our data manager, Scott Cohen, and our biostatisticians, Dr. Michael Weaver and Kai Yang. And lastly, I really want to thank the fellow emergency physicians in the midst of this pandemic and COVID-19. You guys may have thought that this is actually a pocket square, but it's my surgical mask when I have to walk back across to my office. And we've all had great sacrifices in the midst of this. I really hope that in the future, we could do this in person and have the camaraderie and scholarship that SAM is all about. Thank you.